Hello and good afternoon, morning, or evening, depending on where you are in the world. Thank you for joining us for this very interesting topic. Now, I think I have to highlight very importantly that we have a very unique situation here with all of these gentlemen at the moment. We're missing our lady, who have come from all parts of the world to share their scientific knowledge about what is happening with COVID-19. And it is a great honor that I have them all here today with me. And especially, I mentioned Ivo because it's very early in the morning where he is in Japan. We really, really appreciate that. And it just shows how important this is for everyone. So just to do a quick introduction for everybody, and we'll start with Ingo, if you can go ahead and just let everybody know who you are quickly.
Okay, I'm Ingo. I studied chemistry and did my PhD in immunology, and been working with dendritic cells, which is antigen-presenting cells, and worked on its activation by mycobacteria, and later on cancer immunotherapy.
Wonderful. And Knut?
I'm Knut Wittkowski. I'm originally from Germany, where I got my education in statistics and epidemiology. And then I moved to the United States to work at the Rockefeller University to head the Department of Biostatistics, Epidemiology, and Research Design. And then I left Rockefeller and started my own company to develop drugs and nutraceuticals, including some that might be working against COVID.
Wonderful. And Ken, how about you?
Yes, so I started out at the University of Texas to receive my PhD in cell and developmental biology. And I moved from there to into more myogenesis and aging work. And then from there, I got into genomics about 10 years ago, and currently I look at both genomics and epigenetics. That's been my main focus.
Wonderful, thanks. And Ivo?
I mean, my background is quantum and solid state physics, and I'm working on simulation of materials properties in various applications for my own industry, which is my own means in my area, which is semiconductors and sensors and some other kind of active devices. So coming from one area to another, the main reason for that trigger was the need for a very targeted scientific information and informatics modeling about predicting properties of affinity interaction of different enzymes, proteins with viral parts of this kind of new virus. So this was my involvement. Wonderful. And also being in Japan make a big difference.
Yes, it does. And James?
James Lundeen, Electrical Engineering, University of Illinois, thesis master's in chemistry, computational chemistry, Illinois State University, Normal, Illinois, Chicago Medical School, MD, and I'm founder of Lundeen Software and Sir Isaac Newton Enterprises. My focus is on the acid-base dissociation curves with complex pharmaceutical compounds, and I've put most of my time this past year into looking for a common denominator in the comorbidities that present themselves at the hospitals with people with moderate and worse cases of COVID-19.
Wonderful, wonderful. So thank you all very, very much. And so I think that what we're going to probably be starting with is the big question about what happens with regards to vaccines and where we are. And I thought probably the best person to talk about this would be Ingo. Ingo, where are we at the moment in the world with regards to vaccines?
So I just did a quick search this afternoon on the figures, and well, we had since the rollout of the vaccines, probably approximately 3 months, and it is depending on where you look, very different. So the US managed to vaccinate roughly 100 million people, which is 31%. Israel 5.3 million, UK 31.3 million. The European Union 5.3 million. And if you look at Africa, for instance, they only vaccinated in 3 months 0.6% of its population.
Now, are we setting up now for a situation where only the first world countries are getting vaccines? Is that where we are effectively?
Yes, I think so, yeah. So you see a lot of hoarding of the vaccines. You have some like Gavi, which want to give to the third world countries vaccines, but the supply of the vaccines is so scarce at the moment that you don't get enough vaccines to all people in the world. So basically, what we need to achieve is to get an equal distribution of the vaccines to in the world, meaning that probably 75% is of the population is vaccinated worldwide, is vaccinated within a very, very narrow time window.
Wow.
Otherwise, we might run into really difficulties with the virus that is mutating already very, very fast. So I think, if I'm not mistaken, Knut, it is every 3 months that the virus is bringing up a new mutation.
Yeah, so that leads us right into the situation that I probably wanted Ken to talk about. And when we speak about these variants, Ken, where are we now with regards to what's happening?
Yes, it really depends upon geography. Really wanted to emphasize Neil Bodie, who's really been posting a lot on this on LinkedIn. He really keeps track of almost every detail with some of these variants. There was a recent review on March 26th issue of Science that really covers comprehensively a lot on this topic. So, according to the CDC here in the US, there's a lot of variants of concern. Recently, they've been tracking these variants by sequencing. I just want to emphasize that, the use of NGS has really allowed us to track these variants that keep emerging.
When you say NGS, what do you mean?
Oh, I'm sorry, next generation sequencing. So the genomics technology has really allowed us to do this. And because we have it's a major advantage. So kind of in a nutshell, there's kind of 3 main variants of concern that have been discussed. There's the B117, the B1351, and the P1 variants. And it's the B117 variant that seems to be the main concern in the US. And the main concern is, how are vaccinated individuals responding to these particular variants. And so a lot of the experiments have revolved around looking at convalescent sera to see how it's responding to the variant. And in a lot of ways, they showed that there's a decreased ability to neutralize and clear the virus. And also, understanding how it could be more transmissible, and so higher transmission of these variants, as well as whether there's an increase in virulence. And so this has been the main concern about, as these variants emerge, how are we going to handle them, and how are the vaccines going to behave against them?
Well, and this ties right into not with regards to the epidemiology. How do we, because I guess there's a spread of these variants across the world, not just in the US. You know, how is that looking at the moment?
Well, with all the lockdowns going on, and each lockdown carrying the risk of breeding at least one resistant strain, the number of strains and their resistance to vaccines is increasing worldwide. As we just heard, there are 10 major strains right now circulating in the United States alone. 5 of them originated here in the United States, others were imported from other parts of the world. And we will see that continuing, so that the hope that we can actually make or end the epidemic with vaccines is fading away. We need other strategies, and this is where this group here with Philip started. Originated originally to think about a plan B, about something with nutritional strategies or other strategies that can be done to actually achieve the goal of ending the epidemic, rather than breeding new strains every couple of months and then having a new wave of epidemics spreading, something that could potentially last for quite some time.
Wow. And so that leads us right into one of the questions. How are they managing Ivo across the other side of the world? Because it seems as though they are managing this in a different way, or they don't seem to be as challenged in the East as they are in the West. Is that right?
That is right, Philip. And let me put some background here. So main approach of lockdown, maybe definition in Australia, New Zealand, and California may be different from what will be in Japan, because in Japan lockdown means try to do telework, but just try. I mean, they will not count you if you don't do it as a company or as an employee. And second thing, the main thing they do here differently in Japan is they know that closing restaurants and bars at 8 p.m. is the best way to prevent night kind of long drinking parties, which is the most easiest way to get infected. So this is one approach of kind of local management. Second approach is strong ventilation, opening airflow in confined places. Do not have meetings to be done in closed meeting rooms and so on. So it's a kind of strategy of very common sense, but it's been systematic. Why is systematic here? Because people have been told in the beginning from the authorities, and people, as you know, our Asian in general, maybe Southeast Asian, they're very obedient. They're very kind of with high cautiousness of let's try to not harm each other. Let's follow these common rules. So it's very easy to kind of achieve results here without mandates.
Yeah, that's an important point, because it seems to be making a difference. But when we think now as we move forward, and I'm going to pull James in here, and when we look as going forward, if we don't have a coherent or a long-lasting strategy with regards to vaccination, how are we going to protect people? And this is the purpose of the Plan B. Any ideas in terms of therapy?
What I've found from looking at a lot of published articles is that the comorbidities have a common denominator of vitamin D3 deficiency, and that's tied into an elevation in fibrinogen levels. They're inversely related. If you have a deficiency of the D3, your fibrinogen level is high, and that's important. That's factor one of the clotting cascade. Fibrinogen can activate platelets. Fibrinogen binds insulin, binds glucose, binds streptococcus bacteria, binds cancer cells. It's sort of a glue, sort of an all-purpose like duct tape. And the fibrinogen levels on the scale on which it's measured is usually 200 to 400 units, and 250 is a good number. And a number of people who are hospitalized with COVID-19 have a level above 400, and a number of them above 700. It's important to bring that level down quickly. there are a variety of therapeutic approaches that can be used precipitously at the hospital door. And we might get into that here today.
Mm-hmm.
And the bottom line is to restore your health as optimally as you can, because the vitamin D3 is a common denominator to most diseases, both physical and mental. It's not the only component, obviously, but it's a foundation of good health, or the opposite. So if we can set new standards for what is a normal D3 level, rather than just bone and skin and teeth health, but immune system health, I believe that we will see much less morbidity and mortality from these respiratory viral diseases.
Yeah.
This is only one of the ones we've seen over the last century, and there's certainly more to come. We need to be more attuned to the actual vitamin D3 requirements. And I believe that one of the ways to determine what's necessary is probably on an individual basis, what level of average daily intake is required to maintain your fibrinogen level around 250 units.
That's a really, really interesting point.
So you have to have a way of doing this, and one size does not fit all, just like shoes and gloves.
Yeah, and it raises another interesting area that you had mentioned before, Knut, with regards to, you have been focused on cyclodextrin. If you could just take a couple of minutes and explain how this is relevant in terms of COVID-19.
Okay, I think it is important to really understand the mechanism of action. And that is something that we often don't fully understand with vitamins and minerals, but we know they're important, and if we lack them, then we have a higher risk of having severe diseases. But we don't really understand how that works. So during the 20 years I was at Rockefeller, we developed a statistical approach that allows us to better understand the genetic risk factors of common and complex diseases, including age-related diseases and the comorbidities of COVID. Most people don't die of COVID or don't even have a severe phenotype. It is primarily the people who have comorbidities, and among these comorbidities, we have obesity, and we have pre-diabetic conditions that are of particular concern. And luckily, we were able to identify, and these components are approved, have approved health claims in Europe. So all Americans have to stop listening right now because the FDA may not like it. In Europe, we can use alpha-cyclodextrin to reduce pre-diabetic stages, and we can use capric acid to reduce obesity, or to help with reducing obesity. And so if you take that together as a synergistic intervention, nutritional intervention, then that may help to reduce the risk factors that lead to more severe forms of the disease. And if nobody dies, or very few people die, and most people have only a very mild form of the disease, then we can avoid, or the need for severe restrictions like lockdowns or travel restrictions could simply go away, because it would become a more manageable flu-type disease that wouldn't require these severe restrictions that are currently imposed in many parts of the world.
Yes, quite right. And as we think about some of the other options, one of the questions that came up that I just want to highlight specifically with regards to Ingo, any thoughts on this big issue about nasal or mucosal vaccines?
Well, I think, in my opinion, it's the best way to eradicate this virus, because I think you have to have IgA, which is a certain type of antibodies that is produced in the mucosa. And you can achieve mucosal immunity either by administering vaccine through the nasal, like a nasal spray, or oral. And there are some interesting approaches ongoing. For instance, Finland, which had already a patent-free vaccine by mid last year, but they couldn't somehow develop it, and they made it a nasal one, which they founded a company in the meantime and trying to produce this vaccine. And there are also other companies. There is a British company, for instance, which was called Stabilitech and is now called IOS Bio, which is cooperating with an American company which is called Immunity Bio, that is developing a nasal vaccine. Yeah. And there are also rumors that even AstraZeneca and Sputnik, so the Russians are producing or at least making an attempt to use nasal vaccine.
Yeah, and this is an important point that somebody has just highlighted here about the true disruption with regards to the nasal vaccines. I can only highlight from my own research that we're doing. One of the tricks that this virus uses, and this is what differentiates it from many of the other viruses, is that it's able to evade the normal system of interferon production. And so because of that, it gets quite far down into the lungs. And if you had a way of the body recognizing the virus, it would then allow us to be able to mount a response quite early. I notice you nodding there, Ken. Any thoughts on that?
Yes. So, early on in the pandemic, I read the perspective of a doctor in South Korea, Hyung-Sik Shin, and I also have a friend, Marco Sanchez Gonzalez, and we've discussed a lot about, trapping the virus early, in the upper respiratory in the nose, is really key. There's some really interesting mouse studies showing that, it's fascinating how the body knows when you get infected, in that the lungs start to prepare for a respiratory infection. And there's some really interesting papers on this topic. And what they've shown is that, if you can trap it in the nose first, it allows the lungs to prepare and kind of get ready for as the virus makes its way. And so there's also a lot of, connections to allergy in this whole immune response that are very interesting. But I think, that's one strong possibility is keeping it in the upper respiratory, a little bit longer before it can spread deeper in.
Any other thoughts? Yeah, go ahead. Yeah.
Ingo, can you tell us what is the differences in nasal vaccine approval procedures versus the conventional one?
I think they're the same. So they have the same approval as a regular vaccine. So, but I think the distribution is easier, and it has a different formulation. So, for instance, the oral vaccine, so at least the one I read about, can store it at room temperature. So this makes a big difference if you think, for instance, of Africa, or at least at regions where are high temperatures and where you can or it's difficult to cool down and have coolers for your vaccine, and even the distribution. So if you don't need an MD around to administer the vaccine, just let's say a nurse which is observing if the patient develops some side effects, and just some regular phone calls. This will speed up the whole vaccination process very, very much.
No, it raises a question. I understand what has happened in terms of the first world, but why are not other countries who are struggling to get access to other vaccines not being more proactive with regards to something like the nasal vaccine and using that much more? I don't understand why the rest of the world is almost sitting back and waiting. Any thoughts on that?
I mean, I can only say that Japan won't lead that because they like to follow what other countries do first, and then easy to criticize from that point of view. For example, they approve only one vaccine now when other countries approve many more. So I think the main reason is you need to have a leading company, I don't know who is that one, that want to lower the profitability, because I think this vaccine maybe have lower margin than the conventional ones.
That's a very, very important point. It's frightening to think that that would be the main driver at the moment in the context of a pandemic, but it does seem as though the financial rewards for some of our big companies is driving a lot of the politics. Is that an unreasonable thing to say?
I don't have the numbers, but I assume that is most likely the case.
Right. And what about the thoughts of something like ivermectin? I think, James, you probably, you're muted at the moment, James, but you probably have some thoughts with regards to why is ivermectin not been given the approval that it needs? You're on mute, James. You have to unmute your mic.
Okay, he is.
Yes.
I believe that because it's off patent and it's manufactured in many different regions of the world, it doesn't make any business sense to pursue it.
Wow. That is
That's
very,
the main
very
driving force. Yes.
I think that is a general problem, that the financial aspects of an intervention are considered primarily, and that is the same with nutritional interventions that also are being considered to be less lucrative and therefore are not pursued at with the same intensity as the vaccines are.
That is actually something that one is seeing more and more at the moment, and it is very, very worrying that this is the strategy that we're seeing, because ivermectin has been stopped as well by the WHO quite recently, and I don't think that they think there is enough evidence that it works, but it is still a relatively safe drug. And it would fit right in with the fibrinogen, wouldn't it, James?
Absolutely.
Any other drugs, James, you can mention in this discussion?
Well, the dexamethasone can precipitously drop the fibrinogen level at least 25% within a very short time.
Okay.
The D3 there's a lot of mixed studies on the D3, whether or not you can drop the fibrinogen level quickly. Fibrinogen has a half-life of 4 days, 96 hours. You can get the fibrinogen level cut down by half or even by a third within a couple of days. Hospital stays are not a week. Generally, they're a couple of weeks if you're bad enough to be in the hospital, whether it's a ward or intensive care. So you can get a jump on things. So the dexamethasone or the ivermectin or a simple plain aspirin on admission may give you some time to get the D3 level adjusted properly by daily dosing or a continuous drip.
Yeah.
You need to get your D3 up anyway.
Yeah.
People who are showing up there, 80% of them are D3 deficient and they're below 15 or 20 nanograms per ml.
Yeah, I'm going to highlight a point on this, James, because I'm not sure if a lot of people realize this. The infection or the inflammation in the lungs doesn't actually kill someone. It may make you a little bit short of breath. What is causing the mortality is microthrombi. That's little clots in the lung vessels all throughout the lungs. And this is why people who have lung disease are more at risk, because they have less reserve in the lungs. And you're absolutely right, James, is that it's the small percentages with reducing the amount of little clots in the lungs that can make the difference between life and death, or admission or not.
There's too much pulmonary fibrosis starting with these people who have significant COVID-19. Because the process of the macrophages and all of this, you end up with fibrotic tissue. And if you have most of the lung tissue matted together, you don't have a football field full of surface area for gas exchange. You might have the size of your small rug in front of your couch.
Mm.
You just have no physical endurance. You can't do anything without being exhausted and out of oxygen.
Yeah.
So I would like to add one point actually in support to what Philip just said is we are not dying of the virus infection itself. We could live with that virus forever. We would produce a couple of viruses and we can well do that. We die of the consequences of the immune system killing all infected cells at the end of the incubation period, including cells in the lung. And that huge wound and all the consequences that come with the body to have to heal that huge wound is what's killing us.
Spot on.
Yeah, quite right. And so one of the other things that has been highlighted recently, and I'd be interested to hear the views about this, is the concept of vaccinating children. Any thoughts? Anybody wants to take that on?
It's very difficult from an epidemiological perspective. It's very difficult to see why one would vaccinate children who don't have a severe phenotype, who are infecting each other relatively easily and contribute to the build-up of herd immunity without the need of any vaccination speeding that up. So it is not really easy to see why one would vaccinate children for a disease where children have a very mild disease and own phenotype, while it is the elderly who actually suffer.
Yeah, quite right. James, you were going to say something on that point.
Very much in line with what Knut had to say is that if the children have a special situation such as trisomy 21, Down syndrome, or morbid obesity, or other particular unusual situations where they're more like an adult with all sorts of comorbidities, I think it would be important to consider vaccination, but not in general, no.
No.
That's a decision to be made by the physician, the individual physician, and not a decision to be made by the government.
Absolutely. And what would be the thoughts on the eastern side of the world, Ivo? Have they had any thoughts about that?
There was a question in the national parliament in Japan several weeks ago by the opposition parties saying, why you're not preparing to vaccinate the children? They need vaccine. There was very kind of sudden this kind of question, which was surprising. But I think this question is somehow coming from maybe, again, as we mentioned in the beginning, maybe some other agenda, which is profit or something else. So the good news in Japan and the East is that schools are open. They've never been closed. And we know that infectious route through the children is not the main one for bringing the elderly people under this risk and of dying and going to the hospital. So at least here, they know that the children are not the problem. Maybe we can make a problem by mandating vaccinating them, but in Japan, there is one more strong kind of constitutional right. Without consent of the both parents, you cannot touch any child in Japan about vaccination.
Ivo, do you have an idea how the rate of teachers that got infected in school is, or are there? And I assume there are some.
There are some, but I have not seen any publication in Japanese university or such kind of academic publication about such kind of studies. So this is there has been a cases several months ago that some school has been closed for several days. Definitely there is a cluster of possibility of infection, but not in what is happening in the United States, that the teachers unions is preventing children to go back to school. That is not possible in Japan.
From the epidemiological perspective, I'm not aware of any studies showing that teachers are at a particular risk. On the contrary, in France, they have done a pretty large study and showed, like what people have seen in other parts of the world as well, that teachers are not at a higher risk than other people.
Yeah, unfortunately, Sweden missed the opportunity just at the beginning to study how the transmission from students to teachers would be.
Yeah, somebody raised a question here about the zinc and probably some of the other simple mechanisms that we don't really do in COVID-19 and the virus entering cells. Anybody have any thoughts about zinc?
I will say only one thing. It's been recommended and makes sense to general biochemical activity of the zinc, that is some kind of antibacterial and also have a lot of immune stimulating effects. So I'll say zinc, magnesium, definitely need to add this, or at least prophylactically take from time to time to make sure that they are not deficient depending on your diet.
Yeah, good point. Ken, I just wanted to ask your thoughts with regards to what looks as though it could become almost a COVID apartheid across the world, where some countries are vaccinated with passports and are traveling, and then you have developing or second world countries struggling to get that and being locked out. Is that a realistic situation?
Yeah, I mean, I think when you have a lot of resources being poured into, we don't see it as some countries just don't have these opportunities like we have to develop these new approaches, vaccines and whatnot, and so I really think it comes down to whether we're able to get what we develop and get these to other countries, or are there more ubiquitous means to suppress severe COVID? Could this be done through things like vitamin D3 or ways to treat that's more ubiquitous, that doesn't require ways to get these treatments to countries that can't get to them?
Mm-hmm. Yes, this is a real challenge for the rest of the world, and one has to accept that when you look even at Israel and the response that they had with vaccination, it was quite remarkable in terms of the drop off that they had with infection rates and so on. But that being said, they're still getting significant cases every day. Any thoughts about what has happened in Israel?
We have seen in several countries that the drop in number of deaths, which I consider more reliable than the cases, which depend on many other political and environmental factors, that the drop in death that we have seen a year ago and that we see now is very similar. And it's very difficult to see that an effect of the vaccines when you are just looking at the trend of the number of deaths declining after the epidemic has reached a peak.
Mm-hmm.
So I want to add the following, Philip, that if you compare Japan and Israel, which is very different systems, but have one thing in common, they have similar population density, about 300, 350 per square kilometer. As you know, Japan is doing the same trend as Israel without significant vaccination. Only vaccination here happening to the medical personnel. So obviously they are not the most vulnerable at the moment. So I would say so much effort in Israel is astonishing as a discipline in the logistics, but I think the mechanism is not clear if this is coming from the vaccine.
And you raise a point there, is that what is the perspective in Japan with regards to vaccines and vaccine hesitation?
Okay, because this question is in the parliamentary debates every Friday, let's say, or every week. They will try to speed up, but now because of being cautiousness and also because of a lot of warming exercise, they do very carefully. They don't do chaotically here. They prepare every small community to make sure that their medical nurses and others are prepared how to handle it, and then they distribute the vaccines. So I think by May, they're claiming that they will start vaccinating people 70 and older. Let's see what happens at that time. They are not going to allow yet to the general public until they address the most vulnerable.
And so when we do it, let's take vaccines out a minute, because part of the reason why we are having this discussion is, especially for countries that aren't getting the resources to be able to vaccinate their populations, what is the perspective about what they can do? I know that we've mentioned vitamin D. I know that we've mentioned ivermectin, zinc. Is there anything else? Cyclodextrin, is that freely available, not?
Cyclodextrins are widely available. In fact, we are eating a lot of that even without knowing it, because it is part of our of much of the food that we buy, much of the prepared food that we buy. And it may well be that some people have a mild phenotype just because their food already contains a lot of alpha-cyclodextrin. The problem there is to get it absorbed from the intestine, which requires often a component of milk or coconut oil, and that is capric acid. And if that is put together, which is what we have created, a compound, then alpha-cyclodextrin gets reliably absorbed and can do in serum what we wanted to do, and that is to reduce endocytosis, the uptake of viruses into cells. Now, this has not been approved by the FDA, what I'm saying right now. So if we are reducing the uptake of viruses into cells by only 10% for each of the 7-hour cycles of replication, we have reduced over the 5-day incubation period the number of cells that get infected by about 85%. And if so many fewer cells get infected, including in the lung, then we have a much milder disease, and people wouldn't die anymore because we can survive the wound that is created when the immune system kills all infected cells.
Yeah, go ahead, Ivo.
I just want to add a few other things that I believe strongly that in addition to what Knut is saying, which makes a lot of sense to me, and the lack of approval for me also showed there could be another kind of, again, a monetary related issue. So I want to say only one thing, that essential fatty acids, doesn't matter how you classify this class of compounds. I mean, omega-3, Q10, and a few others, which include this coconut oil-based fatty acids. All of them are very essential. And I think people are deficient with them for several reasons, dietary reasons, processed food, and so on. So we need to emphasize on those. In addition to that, I think we have many other things which has not been tried, but at certain moment need to be developed further. Inhalation. If you go to the doctor to see your throat in Japan, you always get mandatory salt, steam, or some other containing sodium or potassium compounds into this in your kind of breathing for 5 to 10 minutes. So I mean, you need to go to this kind of preventive action to help the lungs, to help supply them with the right moment, rather than waiting for extremely complicated logistics, which may take many, many years to get to 70% of the world population.
Yeah. And Kenneth, one of the things that you have a great interest in is mast cells. And there was very early on some discussion about some of the antihistamines being of value in terms of COVID-19. Any thoughts about that?
Yeah, that was something. I'm sorry that Nicole Eisenhauer couldn't join us this morning, but she is absolute expert on this topic. So early on in the pandemic, probably about a year ago, I got interested in these connections with allergy. We started to look at the role of mast cells, and as more research has come out, we've seen that mast cells play a central role in this severe disease. And so one interesting connection is the role of quercetin in possibly acting as a prophylactic, as well as being able to inhibit the mast cell activity. It actually has been shown to block the MRG PRX2 receptor, and it has this potential antiviral activity. And there was a fantastic review by a guy named Ruben Manuel Biancatelli, who basically reviewed the role of quercetin together with vitamin C and how those kind of work in concert. And it interestingly, I thought it was a pretty very great review that kind of covers lots of aspects of this particular component. It's safe, it's available, it's in our diet. And interestingly, it wasn't very well received. In fact, he kind of got knocked a little bit about this particular review in some medical literature. But I thought it was very well done. I think it has some strong potential for sure in being able to handle, the role of the mast cells and how do we suppress them from degranulating and kicking off a very terrible process.
Yeah. I'm going to take James a question on this here, because you understand a bit more from the business point of view and the pharmaceutical point of view. What goes in the thinking in those situations when you come across a drug or a therapy that has no real profitability? What happens?
Well, you look for a different targetable step in the process, either before or after that step.
And if there is no money to be made, is it then sidelined? That's a real question.
I think they move on from small molecules to biologicals because there's still some patentability in biologicals, even if it has an analogous role to a small molecule.
And so who is responsible then to make products that have no real financial value to a company, bringing those forward? I mean, how do we get that kind of force happening?
Our overall system isn't set up to reward that situation.
Yeah, that's the truth. Yeah, that is the unfortunately. And we're in the middle of a pandemic now, so everybody loses. You would think that we should be able to think beyond that at this point.
It's hard to go to people's motivations. All you do is get in a fight. I look at the facts, I look at the science, and I keep my nose straight forward on that.
Wow. And so any other thoughts, guys, as to where we could be going in the future?
I think what comes out of this discussion here is that nutritional interventions, and that includes zinc, that includes vitamin D, that of course also includes capric acid and alpha-cyclodextrin and others, need to be considered more carefully and more broadly, because it is something, if we are helping our immune system to be more efficient in dealing with infections, We are dealing with all of the viruses that are circulating at the same time and all mutations that might arise. Well, if we are focusing too much on vaccines, we always have a very narrow spectrum and if we are at the same time looking down and flattening the curve, we're each and every time allowing the virus to escape again, make new mutations, and then we are starting from scratch. So that strategy carries the risk of going on forever and ever. Well, if we would work on improving the natural reaction of the immune system and just make sure that people don't die and don't have too severe phenotype, then we could get over this and end that epidemic in a very short period of time.
Absolutely.
And Philip, I want to add one more thing, that this approach that Knut just recommended, they actually make sense for the 70 years of age and older, because if you just vaccinate them, you get only 15% efficiency. And if you stimulate the immune system for a few weeks before the vaccination, you get back to 80, 60%. So why this has been ignored? Obvious reasons, because we want so-called automatic stamping rather than solution for each populational needs. Each group requires special treatment.
Absolutely. And where is the WHO in all of this? Why are they so quiet? I don't know if Ingo, if you've had any thoughts. I'm pulling you in on this one.
Well, I really have no idea. So, yeah, I really was hoping you chose someone.
Well, so is there any thoughts, anybody, as to we're here in this situation? Go ahead, Ken.
Yeah, I think one just general comment that I'm kind of coming back to is, this idea that, just by keeping the nose moist, in California and in the West, you constantly find your nose drying out really fast. There's just not a lot of moisture in the air, as opposed to when you live in the South, it gets really warm and very moist. So if you think about this idea that the moisture in the nose could make a difference, or maybe just a simple nasal spray just to help, kind of trap it in the upper respiratory, something as simple as that could be beneficial.
Where you said nasal spray, what comes to my mind is Myotocaraganan. I think they're over-the-counter drugs, nasal sprays, so you can use them, and they're proved for reducing at least flu, but I think they also bind to COVID, to SARS-CoV-2, and don't let it in your system.
Absolutely. You were going to say something, James?
Oh, you're asking about the WHO. I think all of these major agencies have to move slowly and cautiously and weigh all of the information that they have. All of us are on a learning curve. We're all learning something every day if we're paying attention and working hard. And with agencies that have to balance politics as well as science, I wouldn't want to be part of it.
Because they only focus.
I wouldn't want their job.
Yeah, absolutely.
So the discussion about the nasal sprays raises one important issue that hasn't been discussed very carefully, I think, is that we actually have three areas of the immune system that independently work. One is the natural immunity with IgM, mostly at the nasal, at the mucosal level. Then we have the neutralizing antibodies that capture viruses while they're circulating. And then we have the T-cell mediated antibody that kills all infected cells when the virus gets there, after the virus gets there. And these three levels are often confused. They act more or less independently, and keeping all of the spectrum in view is something that will help the discussion.
Mhm. Absolutely. So, gentlemen, we're coming now to the end, and I want everybody to just give a thought as to where we are now, where we're going. What's your closing thought to people as they reflect on where we go from here? I'm going to start with you, Ingo. Do you mind?
Well, I think we can't rely solely on vaccination. So we have to prepare ourselves. So we have to do, or we have to look out for ourselves what we can do to promote our immune system, to help the immune system cope with the virus. We can't probably prevent prevent us from getting sick, but we can prevent our immune system from overreaction. So as James already mentioned, we can use vitamin D3 to level down our mast cells so that we don't see cytokine storm.
Mm-hmm. Absolutely. And Ken, any final thoughts?
Yeah, so one thing that I'm especially amazed by is just how much discussion happens, especially on a platform like LinkedIn, among various people. There's all kinds of very knowledgeable people, all posting different perspectives, keeping up with scientific literature. It's really amazing how much you can learn just from others and various people who may not be experts. And so we can learn from each other and continue to kind of discover new ways. I think, if we think we're almost in a lot of ways kind of full circle back to where we were a year ago, as a lot of these variants are emerging. We need to go back and think about the beginning when we were talking about drug repurposing and more ubiquitous treatments. And I think we're kind of full circle back to the same idea of where we started. And so can we have more supplements and basic approaches that's more ubiquitous for many populations around the world?
Absolutely. And Knut, any final thoughts?
Yeah, I would like to just go on and agree. We are back where we were before. And actually, we are now in a worse position than we were before. Because a year ago, we had essentially one strain that came from Wuhan and then in Milano mutated, that was the 614 strain. And that was one strain to deal with, and that was a situation where if we had had a vaccine might have been quite effective. In the meantime, we have, as I said, 10 major strains in the United States alone, and many more across the world. And so the idea of fighting with a vaccine is not enough. We need to do something else. We have lost a lot of time with the lockdowns, and we now have to find a strategy that has an effect that is much broader than the effect that we have with vaccines. And we have to bring that to the attention of the politician, or we have to ask the politician to listen. Because if they don't change the policy of the lockdowns, this will never end. And I hope that the politicians who were waiting for the vaccines as the silver bullet will see that other strategies about nutritional supplements, about other preventive measures are much more effective than lockdowns and vaccines, who are often contradicting each other and are just preventing us from getting over this epidemic.
Well, thank you, Knut. And Ivo, any thoughts? Any final thoughts?
I mean, I just want to say the following. It is clear to me that instead of focusing on PCR tests and vaccinations and partial lockdowns, whatever you call them, which is kind of obvious, historically established strategy need to evolve. We cannot keep the old strategy saying plan A is working when actually is not obviously working. So my opinion is that let's do testing of the antibody of the people, select the people that have some already existing cross immunity, pull out them for the necessity to be vaccinated, mandatory or not, depending on the country policy, and focus on the people with highest mobilities and highest risks. That is my approach. And during that time, when you're waiting for these scarce vaccine resources, strengthening the immune system naturally, exposing ourselves to sunshine, taking essential fatty acids, including omega-6, 3, 9, coenzyme Q10, and of course capric acid and few others, including even simple aspirin. Do some things that can be preventive and safe to the people. That is my approach.
Well, thank you very much. And James, any thoughts?
We need to prevent infection because long haulers is a nightmare. And fibrinolytics will be a new area for research and development. The drug companies will make a fortune on fibrinolytics.
Oh, wonderful.
Very good, James.
Yeah. Yes, so thank you very much, gentlemen. It's been a pleasure to have you all here today. I know this would be of value to listeners. I don't think this will be the only one that we have. I'm sure we're going to have more of them. I think that the value that is coming from collaboration is testament to what we have here today. And so thank you very much again, gentlemen, and thank you for taking the time. And we look forward, hopefully, to speaking to you all again in the future.
Thank you.
Okay.
Thank you, Philip.
Thank you, Philip.
Thank you, Philip.
All right.